And can everyone in the Zoom hear me?
Yep.
Wonderful,
I
thank
can
you.
hear you.
Would any of you like a script to follow along with? I do not have the citations and the references in, but I thought it might make it easier for anyone who might want to follow along. No, and if anyone's on the Zoom call, if you would like a copy of my script, let me know. Just, send heather.brown@stcloudstate.edu a message and I will go ahead and send that to you. And would you happen to like a script or?
Sure.
Okay.
Appreciate it.
Absolutely. Okay. Mind if I stand over here so I can
Yeah.
control it? So, and I apologize.
Because then you can be in the picture. Because you're not, yeah, you're not in the picture. It's
Okay. I mean, no one needs to look at me, but that's fine. I mean, you can all see my happy or hear my happy voice. So, and I want to say I'm going to actually read from a script today. I have had a slight fever all week and my brain is a little bit like soup. And this is a really important issue to me. And it's kind of complicated. And so I wanted to make sure I wasn't going to miss anything important. Normally I'm a little bit different when I do my presentations, but here we are. So we're going to get started. And I really want to thank everybody for coming today. We're talking about gender, weight, and disability and how intersectional bias can affect how you access healthcare, and then also what we can do about it, because that's something that's really important to me. Is I don't want to just give you a horror show. I actually want to, leave you with some ideas of what we can actually do to affect change in our individual selves and in the community as well. So I want to say hello and welcome. My name is Dr. Heather Brown, and I am the director of the Women's Center here at St. Cloud State University. And my own research primarily focuses on improving academic outcomes in underserved and stigmatized populations, with a specific focus on exploring the connections between weight and learning in women at the post-secondary level. And I'm also really active in work around mitigating and ultimately ending weight bias in healthcare professions. And I am the co-editor of Weight Bias and Health Education, Critical Perspectives for Pedagogy and Practice, which was published as part of the Routledge series of Sociology and Illness series. And I am sorry, but someone's calling me from Florida. So I have friends that are down there surviving the hurricane. So everyone's trying to let me know everything's okay. Thank goodness. So before we get started, I want to give some content notes and set some expectations for our time together here. First off, language. I'm going to be using the word fat throughout my presentation. And for many of us, particularly in American society, this is likely to be a super uncomfortable thing for you. And I certainly grew up myself knowing that fat was an insulting word. Indeed, research shows that for many educators, being fat is the, quote, worst thing that can happen to someone. In my framework, however, in the framework that drives my work, we actually interrogate how language is used. And the word fat is actually used as a neutral descriptor. And fat is used here in that spirit. But I do want to acknowledge that not everyone is comfortable with reclaiming a word that has been used as a slur. I also will not be using words like overweight or obese without scare quotes, because those words are neither neutral nor benign. And they are rather used to medicalize a person and conflate their very existence in a higher weight body with being in a diseased state. Second, my work in both the student support and the healthcare education arenas is from a weight neutral perspective. We are not here to talk about weight loss. We are not going to talk about the correlation or lack thereof between weight and health. This presentation will not posit weight loss as a solution to bias. For me, asking the stigmatized to change themselves to end bias and discrimination against them is a complete non-starter. It's not even something that we should be spending our time on at all. Next slide, please. And some expectations. Our time here together is really limited, and this topic is so complex. And of necessity, this presentation is not going to be super in-depth. My own area of focus is more so in the weight bias areas of intersectional bias, with a small secondary focus on gender bias and a much lower focus on disability bias. And so my presentation does skew towards the weight bias portion of the intersectionality spectrum. In this presentation, I'm going to give a broad overview of how weight bias, gender bias, and disability bias affects individuals experiencing that bias, and how intersectional bias negatively affects how individuals with multiple intersecting identities access medical care and interact with healthcare providers. I also want to leave us with some good ideas for what we can do to end this bias. And finally, a content warning. In this presentation, I'm going to be presenting some images and some information that could be really painful. This is going to be included, but not limited to, issues around bias, discrimination, abuse, medical malfeasance, gaslighting, and even death. So please, if you need to step out, please do so. Take the time and the energy to take care of yourself. And I'm also very happy to speak with everyone after the presentation if you want to talk more in depth about these issues. Next slide, please. So we're going to get started on weight bias. Because this is sort of the core of what I really want us to talk about. Implicit weight bias, and this means sort of unconscious or weight bias that is not, consciously acted upon in interactions between people, in current healthcare professionals and students, is widely documented in the literature. In one study, 74% of medical students exhibited implicit weight bias, and 67% indicated actual explicit bias, which meant acting on their biases against people who were fat. Students in postgraduate training in the health discipline often observed weight stigma in their training, so their professors were showing implicit bias. Weight bias has been documented in dietetic students and physicians. Anti-fat bias affects physiotherapists, nursing students, physical therapists. Pretty much any type of healthcare profession is found to exhibit weight bias, which makes sense. We live in a society where weight bias is endemic to how we think about how the body looks. More than 50% of doctors describe their fat patients as ugly, lazy, non-compliant, weak-willed, dishonest, and unintelligent. Indeed, quote, physicians have reported that working with obese patients is a waste of time and makes their job less enjoyable. Among nurses, 24% admit to being repulsed by fat patients, preferring not to care for them. And future healthcare providers exhibit similar beliefs. Medical students and students in other healthcare fields have described fat people as unpleasant, sloppy, and lacking in self-control. And so I've got two slides here of various public health campaigns from around the world and how they depict people who are heavyweight. So this first top picture used to be a banner at the World Health Organization. And this is an example of a trope we call the headless fatty, which is where a person who happens to live in a heavier weight body is reduced to a grotesquely round torso and only a torso. And in this case, you can see this individual, his shirt is too tight, his clothes don't fit, his belly is peeking out. This particular campaign here, this was a campaign from the French Ministry of Health. It's an anti-childhood, anti-bias campaign or bias campaign to end childhood obesity, scare quotes. And this particular campaign came from Israel. And the caption says, when your child gains weight, his smile gets smaller. And as you can see, the child's head has been sort of photoshopped to be grotesquely unhuman. This was actually done by a private healthcare company, and there was tremendous outrage immediately upon it being introduced to the public. And it was pulled, but it was still on billboards throughout that particular country. You can go to the next slide, please. Here are some more public health campaigns. This particular one was also very challenged when it came out in public. This came from Georgia, and it was an anti-childhood scare quote obesity campaign, warning, it's hard to be a little girl if you're not. The child has again been reduced to a body. This one is from the Caribbean, where the connection between having perhaps a slice of birthday cake is correlated with being very heavy. And then this particular individual, this is from New York City. This was one of Mayor Bloomberg's big anti-quote obesity campaigns, where the weight is the most important thing again about this person. And the suggestion is that all of these health conditions are specifically tied to the fact that this individual weighs a certain amount. So that's just a little example of some of the things we see publicly. Next slide, please. So fat patients actually face public scrutiny over their right to access life-saving medical treatments. For example, during the COVID-19 pandemic, quote, there has been open debate about whether fat people are worth giving ventilators to. And I don't think we think enough about the impact of hearing your worth of your life debated by the public. And in some cases, such as Hurricane Katrina and Superstorm Sandy, there are a number of documented cases of fat people being left behind in medical facilities rather than being evacuated with other patients, leading to their death. And in one case, during Hurricane Katrina, several medical professionals were tried and found guilty of actually so-called mercy killing fat individuals by injecting them with drugs to kill them before the evacuation. And so there is this lovely campaign that's really powerful called Nobody is Disposable. And it's a grassroots advocacy campaign to get various public health entities to think about how do we treat fat people during crises? Where do they fall in the process? How are they triaged? How are they treated? And so I would really encourage you to go ahead and check that out. It's a really powerful campaign. Next slide, please. So next on our topic of bias is gender bias. And implicit and explicit bias has been widely reported by women about their experiences with healthcare. For example, it's been widely found in multiple studies that women's pain is severely underestimated when compared to male pain. Just because they are women, they're told it's all in their head. And this discrepancy is even worse for BIPOC women, where they're dealing with the multiple biases of both being, say, for example, Black, and the assumptions that Black people feel pain differently, and being a woman where you also your pain is not taken seriously. 29% of women have reported that their health concerns have been dismissed by their doctor, while another 15% feel their doctors think they are lying about their health concerns. Both are far greater than what is reported by men. And almost 20% of women felt that their doctors made assumptions about their health on the basis of gender without asking about behaviors or social determinants of health. And for example, according to a survey by the Kaiser Family Foundation, only 30% of women were asked about their housing security, and only 20% about their ability to afford food or their access to reliable transportation, all of which are social determinants of health. Next slide, please. So bias in healthcare against individuals with disabilities. This is actually kind of challenging to analyze since so much of the research is actually focused on specific types of disability as opposed to disability broadly defined. However, research in 2023 that was a meta-analysis found that people with disabilities are often stereotyped as incompetent, cold, and childlike by their healthcare providers. And that particular study found that the bias and discrimination against individuals with disability may be affected by whether or not the individual being assessed believes that the individual is responsible in some way for their own disability. For all individuals with disabilities, unfortunately, they were seen as ill rather than healthy, regardless of their actual health status. Professional caregivers who had friends or families with disability, however, tended to have lower implicit bias scores, sort of suggesting that if you have interactions with people you care about, then your bias against people with a similar condition will be mitigated. However, a survey of physicians in the United States in 2021 found that 82% of them felt that people with disabilities had a worse quality of life than other people, and only 41% felt confident in their ability to provide quality care, and only 57% would welcome a patient with disabilities into their medical practice. The research team did note that more research is needed, because there just really isn't a lot. And there are 61 million Americans who have some type of disability. So it makes sense that we need to study this more. And I want to, throw a note out here. I mean, Molly and I have talked about this several times. I'm not going to actually answer the question here of whether or not a higher weight body is a disabled body, because it's extremely complicated and it's actually worthy of its own sort of in-depth presentation. Sometimes a fat body is disabled, sometimes it is not. Here, I encourage you to see if you can make accommodations if someone needs it without having it classified as a disability, because that can set up all sorts of really problematic political sort of dominoes. But it really doesn't matter, because when you start looking at how all these identities intersect, wow, it gets wild. So next slide, please. So how does all of it intersect? When you start looking at different intersecting identities, all of which as singular identities are the targets of implicit and explicit bias, the effects of that bias start to multiply. And I love this sentence because it's really true. All the research has really found that persons with intersecting social identities, the combined adverse effects of implicit bias are so much stronger than they would be if you were dealing with just one singular bias or one singular identity. The research really bears this out. For example, while 22% of women without disabilities had felt their health concerns were dismissed by their doctor, 36% of disabled women reported the same. So you've got someone who is both identifying as a woman and as disabled, they're having so much more, they're feeling so much more bias from their healthcare providers. In another example, when gender bias and weight bias intersect, women's health becomes compromised. For existence, obesity, scare quotes, in women appears to be correlated with increased risk from gynecological cancers, but higher weight women are also less likely to obtain screening or preventative care that would catch those cancers at an early date because of how they've been treated by their doctors. So they expect that they're going to go to the doctor's office, be treated with bias, be faced with discrimination, and so they just don't go, and so they don't get screenings. And so by the time their cancer is found, the success rate of treating them is so much worse. And this is actually even more pronounced for women who have been involved in formal weight loss programs, which is almost every single woman in the United States. Women in particular avoid or delay seeking healthcare because of fear of being fat shamed or lectured about weight loss. Reasons for avoiding healthcare that are associated with weight bias include disrespectful treatment and negative attitudes on the part of staff, unsolicited recommendations for loss, embarrassment about being weighed, inadequately sized medical equipment, and previous poor treatment, such as being berated for not losing enough weight while on a diet. And fat people, regardless of gender, like women of all sizes, have often been excluded from drug trials, leading to underdosing of medications, including antibiotics and chemotherapy drugs. And so a recent study found that 40% of fat cancer patients received inadequate levels of chemo drugs, a significant contributor to higher cancer death rates in heavier weight patients. So the question becomes, is it the weight that's killing people, or is it the bias that's killing people? Next slide, please. Despite researchers knowing that intersectional bias is problematic, not very many studies are being published on it. In a major meta-analysis from 2019, they found that most studies on implicit bias in healthcare focused on racial ethnic bias, followed by weight or anti-fat bias. Only about 10% of studies focused on the intersections of race and class, while fewer than 5% of studies looked at the intersections of race and sexual orientation. In other words, less than 15% of studies overall on the effects of implicit bias on healthcare experiences looked at the effects of intersectional bias. And those studies only looked at the intersections of race with class or sexual orientation. A more recent scoping review from 2023 found that racial bias is still the most investigated implicit bias, with gender bias the next most investigated and weight bias the third most investigated. But an intersectional lens was largely absent from the published research. Next slide, please. And it's really important for us to start talking about these intersectional biases, especially as it relates to issues of gender and weight bias, because intersectional bias kills people. And I wanted to share this slide. This is a woman named Ellen Maud Bennett. In her obituary, she said that she was a victim of weight bias, gender bias, and medical fat phobia. And her message, the final message she wanted to share was about the fat shaming she endured from the medical profession. Over the past few years of feeling unwell, she sought out medical intervention and no one offered any support or suggestions beyond weight loss. Ellen's dying wish was that women of her size make her death matter by advocating strongly for their own health and not accepting that fat is the only relative health issue. And she was a director, a creator, a writer. This is her as a little girl, and I like to show that because we often don't see pictures of fat people when they're children. We usually only see like bodies, as I said, the headless fatty. And she died from undiagnosed cancer. When her autopsy happened, she had a huge tumor that could have been treated if she had been given proper care. And she's not the only one. Research has found that autopsies of, quote, obese patients were 1.65 times more likely to discover significant undiagnosed medical conditions that directly contributed to their death. So if they could have gotten adequate preventative care or had their concerns taken seriously, they might have lived. So what can we do about this? And according to researchers, most healthcare professions exhibit implicit bias, and those biases can lead to premature conclusions and misdiagnoses. But there is acknowledgement among a majority of healthcare professions that that bias is problematic. And the hierarchy inherent in the medical profession patient relationship creates this inequality in power, and medical professionals really have a responsibility to use that power differential in the best interest of the patient. And for example, one study found that 85% of OBGYNs require that all patients be weighed at every single visit, even when 56% of patients explicitly ask not to be weighed. As individuals, we have the right to not be weighed, and doctors should not pressure us to capitulate. We have not given consent to that activity, and they should not try to coerce us into doing that activity if we don't want to. And I will say this is something that I experience every single time that I, as a disabled fat woman, go to the doctor for a regular checkup, which is every 2 months. As I simply say, as I'm led to the scale automatically by whoever is checking me in, no, thank you, I do not weigh, and I am not on any medication that is weight dependent. And yet, despite my very clear statement of what I want, I am subjected to multiple attempts to coerce me to weigh. And when I do not acquiesce, I am subjected to rough handling and what feels like deliberate mistaking of my blood pressure using inappropriate equipment for my size. Then, of course, my blood pressure is high. And as a matter of self-advocacy, I actually ask my doctor to take my blood pressure at the end of every visit to get a more accurate reading. And when she does, it is normal because I have calmed down from that very distressing interaction I've had with the person who's trying to force me to do this. But that self-advocacy takes a lot of courage. It's really difficult to push back against an expert who is supposed to be taking care of you, who is supposed to have your best interest and your health in mind. And I will also say that you have the right not to weigh, but if you are taking medications where it would be good to have a weight, or you have some other health condition where weight does really need to be monitored, you also have the right to say, I don't want to know. And you can ask them to take it so that you can't see it when they're taking it. You can turn your back. They can put it in your chart. You don't need to know about it. That's your right too. And I will say, you know, we can do the self-advocacy as individuals, but there are also some systemic things that we can do to sort of alleviate or hopefully even end weight bias in healthcare and other types of bias as well. Next slide, please. So first off, according to the Centers for Disease Control and Prevention, social determinants of health such as poverty, discrimination, access to education and healthcare, pollution, and the built environment actually have greater impact on health than individual specific behaviors related to diet. Changing social determinants of health is really complicated. It can be very costly, but it does require us to have a shifting focus as well as the political will to make changes that don't fall solely on an individual to make those changes. But we as a society must work to make these changes if we truly want to improve overall health outcomes for everybody. Next slide. Second, sorry for this picture. I am so sorry. We need to find ways to promote empathy and compassion without further stigmatizing those with intersecting identities. For example, when we look at weight bias and gender bias, we could rethink what's called the standardized patient model. And a standardized patient is in essence a trained actor who provides an opportunity for future doctors to practice their skills in a simulated training environment. Students in one study who read 2 articles on communication and stigma and were told then to discuss the standardized patient's medical concerns with them actually found that there was an increase in empathy and a lowering of bias when they did that. Unfortunately, it was only found to be effective in the short term. It wasn't found to have any sort of long-term effect on empathy and compassion. Unfortunately, people still reverted to those stereotypes that they had been holding throughout their entire life, what they had sort of taken in from society. Most importantly, however, we need to do away with attempts to develop empathy and compassion by having future healthcare professionals wear what are called bariatric empathy suits, or things that are also known as fat suits. I and other educators have really argued that such practices not only backfire, but are also highly unethical, since fat suits are often used in popular culture as a form of mockery, sexism, and racism. And in preparing for this, I just did a Google search of bariatric empathy suits, and this is what pops up on the very first page. So these are some of the suits that people wear. You can see like how it makes the body look, what it looks like under clothes. And then of course you've got like very slender people who are wearing them. So you have that, again, the weird shape, so look kind of not human. You see how it's like clothes don't fit. I mean, it's really problematic. Next slide, please. Third, more research is really needed to discover a way to affect long-term change in how people have implicit intersectional bias. Researchers suggest that progress towards change in biased attitudes in the United States, particularly around race and gender, have largely been measured by short-term results. You know, we do a study for 18 months and we're like, we're great, we're making change, but it doesn't last. So we really end up with sort of less than optimal, quote, best practices in eradicating bias and discrimination. This has really got to change. We've got to find some long-term solutions. Fourth, the medical professions and indeed society as a whole must move away from healthism, where a healthy body, narrowly defined, is seen as a moral obligation by people who exist. And research suggests that healthism has actually led to the medicalization of the body size and disability, allowing physicians to enact, quote, a duty to treat that gives them permission to explicitly act on pre-existing implicit bias. So if you are in a profession that says you have a duty to make people healthy, if you have sort of unconscious biases, and you have now this duty to treat, you may start acting on those unconscious bias and feel like you're justified. This is, again, another public health campaign for, quote, World Health Day from a hospital. And again, and headless fatty, ill-fitting clothes, and of course, all people who are fat eat lots of cheeseburgers. There's actually an article about this that is one of my favorite I hate articles, where a researcher looked at the connections between weight and cheeseburgers and GPA in college students, and it's all sorts of problematic. But it also gives me sort of a little wicked chuckle every time I read it. Next slide, please. So fifth, we need more and better research on implicit and explicit bias, especially research using an intersectional lens in the healthcare professions. The research has found that only 15% of studies actually explored 2 or more intersectional identities, while only 1% looked at 3 identities. In addition, nearly all research uses the implicit association test, which is really cool. It's a gold standard on bias and discrimination, but it can't be the only thing that we use to think about bias. We really do need to enhance our work with some good qualitative research. We need to talk to people about what their experiences are and learn from them. They are the experts in their own experiences, and we can learn a lot about how we can make changes if we do that. Next slide, please. So I am really happy to report that change is happening, which makes me so happy. In 2020, Black medical students at the University of Pittsburgh School of Medicine wrote an addition to the Hippocratic Oath to address racial injustice and the failures of the medical community to serve all people with the same access to care, dignity, and evidence-based practice. And their new oath includes the following. We recognize the fundamental failings of our healthcare and political systems in serving vulnerable communities. This oath is the first step in our enduring commitment to repairing the injustices against these historically ignored and abused in medicine. Black patients, Indigenous patients, patients of color, and all marginalized populations who have received substandard care as a result of their identity and limited resources. And I would add, people who are living in heavier bodies fall under this new Hippocratic Oath. And I would encourage more people who work in the healthcare professions to include this as part of their own ethical understanding of their professions. So that is my presentation. Thank you so much for listening to me. And does anyone have any questions or feedback?
This is Molly. One thing you were talking about just a couple slides ago was about medical professionals being the experts that we should listen to. That's highly related to disability, right? Disability is something that has been, led by experts, academics, doctors, throughout our history. So I think that that's a really important intersection to think about somebody who is fat and has a disability and is kind of dealing with being subject to whatever their medical professionals are telling them what to do, right?
Yeah.
Yeah.
Yeah, I mean, you go in and you're going in for a complaint that's completely unrelated, or you think is completely unrelated to a particular issue that you're experiencing, and they're just laser focused on one particular thing. And so, listening to people about, people live in their bodies. They are the experts on their experiences of their own bodies. And it's going to take time and it's going to take, patience to really, talk about these things. But people will get better medical care if we really see the doctor-patient dyad as a team and not a hierarchical, I tell you what is going on and you just do it situation. Oh, Janet.
Yeah, sorry, go ahead. Do you know if there's any good research on how heavier doctors and nurses show or have bias against other patients?
Yeah, I can't give you any statistics off the top of my head, but internalized weight bias is a real thing. We live in a society where we get messages all the time that our bodies need to be a certain size and shape to be considered proper bodies, appropriate bodies. And so it can be this very sort of internalized disconnect because, what if you are a doctor and you're having this internalized bias and you're enacting the things that you're told as a medical profession, you should be doing, changing your diet, exercising, having weight loss surgery, and yet things still aren't changing. Like, that's a real cognitive dissonance that happens. And it's really hard in a society where a heavier body is so stigmatized. Like, it's, 30% of teachers think it's the worst thing you can possibly be. And it's hard to shed that. It's hard. It takes a lifetime, and it's a constant thing. There are fat acceptance movements, there are fat liberation movements. I would hesitate to really push people toward body positivity because some of that's being co-opted by the corporations to sort of sell products, buy our soap and you'll feel better about your body, or it's always rah, 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 I have a beautiful body, and it's all about I'm attractive and fun and bubbly, toxic positivity. Whereas some of the more weight neutral approaches is like, we exist in a body. Sometimes my body is great. Sometimes my body is not. Sometimes my body is sick. We're going to look at how to, care for the more holistic body is sort of the better, less problematic way to go.
You had a quick comment in the chat. I just want to read before
Yeah.
we get to Janet. Just says, thanks so much for doing this presentation. Having been more and more aware of this kind of bias and its dangers in the past 20 years. I hope that more people will hear this and other information to overcome and replace it with accurate, compassionate information.
Wonderful. Thank you so much. I appreciate that comment. Janet.
This is Janet. Yeah, I was just thinking through just wondering about what might be helpful models moving forward. So just for context, I'm a professor here, and one of my areas is speech therapy, and I'm teaching a graduate class on assessment and treatment of stuttering. And we've really shifted that model from you stutter, that means you're broken, we got to stop the stuttering, right? To some of the models we use are more informed by like international classification of functioning. So it's sort of like you stutter, what's happening in your environment, what barriers are in place that we need to eliminate. And then there's a lot of focus more on what are the person's priorities, and sometimes there is physical tension where there are specific techniques related to speech movements that are important. Sometimes not,
Yeah.
right? And sometimes there's lots of other things that we're doing just to improve the communication experience. And some of that may be within the person, and some of that is really pushing back against bias in the world.
Yeah.
So thinking kind of like parallel with people who live in fat bodies, we certainly don't want them to be like neglected in care that's appropriate and meaningful, but we don't want them to have assumptions made about like, oh, you walk in, yeah, your arm fell off. Love the cartoon. Your arm fell off, you need to be on a diet,
Yeah.
right? So are there some models that sort of guide your way of thinking to get to that? I don't know.
Yeah, and so there is a framework. It's called Health at Every Size, and it has actually been studied pretty widely in both the United States and in Europe as to if we are truly looking at improving overall health outcomes, how do we do it? And in the studies, they compare people who are on like sort of the traditional weight loss diet focused sort of health promotion group. And then the experimental group are actually just taught about nutrition overall, healthy eating. They're encouraged to move joyfully to the best of their ability when they can, rather than seeing like exercises. I've got to burn so many calories by getting on the treadmill. And when they really started looking at health outcomes, true health indicators, cholesterol, blood pressure, and the various things that you really need to do some more extensive testing on, rather than just measuring someone's height and their weight and doing a really old formula from the Swiss back in the 1800s. They actually found that people who were in the Health at Every Size model showed significant improvements in their overall health. as opposed to people who were going into the traditional dieting model, where they might end up in what's called yo-yo dieting or weight cycling, where their weight's going up and down and up and down. And that actually wreaks a lot of havoc on your physical systems. And so they might actually end up being less healthy because they've been in this horrible weight cycling process. The other thing I think is really important is to think about the effects of weight bias and how much of the bad health outcomes that we correlate with weight are actually the result of various types of biases. So racism, anti-fat bias, other types of bias and discrimination. And I don't know that there are really any accurate studies that were like, if we just treat people as people and we treat fat people exactly like we would treat any other person who might get that kind of an illness, like for example, type 2 diabetes, what would be the outcomes? Because the initial push is always towards weight loss, immediately. Weight loss or weight is now being overweight and obese is classified as a disease. That is changing a little. People are starting to question that. Is that really the case? And so in terms of physicians, if you're not going to totally embrace the health at every size model, which I would completely encourage people to actually embrace it, what would happen to our fat patients if we treat them exactly like thinner patients who have the same illness without telling them they have to lose weight? So just, ask yourself that question. Try that first.
Another, thank you for that. I appreciate knowing more about those models. Another thing that's in my head, I've been in the childcare center quite a bit this week, doing some speech and language screenings, and they have a lot of like fun videos and different things, and I haven't, like, I don't comprehensively know all that is shown, but I know they have some where it's like movement, and some of them will look a little more exercising than others. And I guess I'm wondering, what are your thoughts about, if you could wave a wand, what might that look like for kids in the 5 and under set and what they're seeing on the front end?
Well, okay, so that's really challenging. And, I think it's like a little over 60% of girls under the age of 6 in the United States have dieted already. Eating disorders are often correlated with being exposed to very weight loss focused or weight focused programs in schools. There's a study that came out of Hong Kong where they actually implemented this program in middle schools, and 10 years later, they had a horrible increase in eating disorders. So I think for me, if there was a magic wand, the very first thing I would do is say, teach students about healthy eating without having a weight loss message. And I think for me, this was, I think personally, the tragedy of Michelle Obama's Let's Move program, because it had so much promise. I mean, joyful movement of the body as to your ability is a great thing. Movement is good. I mean, it's emotionally good, it's physically good. But when it's tied with a weight loss message, that can become a real problem, especially because if you are working out, you might actually be gaining weight because you are gaining muscle. So there becomes that disconnect in the program. We think about like teaching young people how to eat correctly. So what does that look like? Get them involved in their food systems, get them out in the community garden, helping, have them grow cucumbers and tomatoes, and then they can have it at their lunchtime as they understand what good food is. So like you can teach the messages that promote health without having a focus on weight loss. Just don't talk about it. It's ultimately in the end, if people are healthy, what does it matter?
And there's that question of just like, do they even have access to those good foods?
Exactly.
Right?
And do they have access to safety? I mean, I did this really interesting study in the Humboldt Park area of Chicago, where we were looking at sort of their people's ability to engage healthfully in their communities. And it wasn't safe for them to go for a walk around their communities, and there were no grocery stores. You know, so if you wanted to go anywhere other than the corner convenience store and get highly processed junk, you had to take 2 buses and carry stuff, and it was more expensive. And, you know, so that's again, the social determinants of health. Can we help? If we can help alleviate that, do a positive based sort of teaching of, we like to move, it's good, it's fun, let's play with our friends. And, you know, here's some yummy food and this is how you access it, and make sure people have the ability to access it. I think we'd see really tremendous changes in overall health outcomes.
I feel like I would add to that also maybe some representation of people of all shapes and sizes and abilities.
Yeah.
Moving and being joyful.
Yeah.
Because sometimes it can slant a little towards like, real buff looking athletic person.
Yeah, a very specific type of
Yeah,
physical
yeah.
body. Yeah, and also, you know, we all deserve a little treat sometimes. You know, let's have a cupcake once in a blue moon, and don't, you know, don't make people feel ashamed for that. I mean, little kids pick that up, and you know, you see them coming home and I can't eat this because, oh, it'll be bad and I'll get in trouble. And, you know, and it's like, even Oscar the Grouch knows that sometimes or Cookie Monster, we can have a cookie. It's okay. Any other questions or feedback?
I don't see anything else online. I was thinking about the impact of like medication for certain conditions that actually lead to weight gain. And then how those people's like experience changes. And they're unprepared because they
Yeah.
weren't maybe not always a fat person and now are, and now I wonder how all of that meshes together. So I just didn't know if you had anything to say about that.
Yeah, I mean, I think it's really challenging because then, of course, you know, they do want you to watch, because then it's a natural, like
Right.
it's what's going on that's causing a weight gain, and unexpected changes in weight, either gain or loss, is a reason just to talk to your doctor.
Yeah.
But I think along the lines of medication, another real challenge is with all the new drugs, the GLP inhibitors, like Ozempic and Wegovy, and how that can lead to changes in the body, and how it's also now being promoted as an actual weight loss drug. And, you know, people are not understanding what are the long-term effects of this. You have to be on the medication for the rest of your life. It can cause all sorts of like long-term side effects, you know, but people are just so desperate because, you know, being fat again is the worst possible thing we can be. And we don't think about, well, it might kill you might kill your pancreas, and then you're going to end up on insulin in 20 years. We just don't know. You know, and certainly people like me who are diabetic, and I actually take Ozempic for my diabetes because I had COVID and it did kill my pancreas. You know, and now I'm dealing with, I am having body changes, but, you know, I do fat activism, and like, how am I negotiating that? And it's a real challenge. And, you know, if we can be compassionate to each other. And I also really encourage everyone listening, don't comment on people's body changes. I unfortunately have had to have discussions with people about this. Don't compliment people on weight loss, because they may come back and say, you know what, I have cancer. You know, just don't. Don't comment on people's bodies. I like your shirt, that's fine, but you know, you feel great. Did you lose weight? No, just don't do it. So.
Well, thank you so much.
No,
This is
thank you.
wonderful. Yeah.
Thank you, everybody, for coming. I really appreciate it.